Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
I've been managing gender-affirming care and providing hormone care and primary care for trans patients for about 15 years. And I think there certainly are a lot of nuances to trans care, but I think basic trans competent care is certainly well within the scope of all primary care providers. And a lot of what it is actually just harm reduction. About 50% of trans women self-medicate, and so I think just offering basic trans care can really help in terms of offering some monitoring, managing other risk factors, safe injection supplies, that sort of thing. So today's talk is really going to be kind of a Hormone 101 talk for a provider who doesn't have a lot of experience but is interested in seeing trans patients. So historically, trans patients needed to have a real-life experience where they dressed and presented as their affirmed gender before starting hormones and needed to meet a bunch of criteria and get a letter from a therapist. Those are no longer the requirements. Most of the kind of expert consensus is that trans folks can provide informed consent to start hormones. Informed consent can be obtained from a trans competent mental health provider in the form of a visit or two and a letter. Also, the prescriber can get the informed consent. That's what many clinics do. So if you're going to be the prescriber getting informed consent from a patient, what do you need when you have a new patient in your office? I think if you're not very familiar with trans care, probably the easiest thing to do is literally sit down with a patient with a consent form printed off from a site like Fenway and kind of go through it line by line with the patient. You want to go over the risks, the side effects, kind of the permanent physical changes, the reversible physical changes, emotional changes. You want to get a good sense of the patient's expectations. So make sure that what they're expecting to get from hormones is going to be realistic. You also want to review social impact. So what is their housing situation, their employment situation, who's support in their life? Do they have mental health issues? And you're not trying to weed out people, but really just get a sense of where they might need extra help as they transition. You want to talk about fertility, particularly estradiol causes permanent infertility. So you want to talk about fertility preservation options. And you also want to make sure that, their goals, they need hormones for the goals. Some patients just want finasteride for alopecia or maybe surgery. And so basically when I see a new patient, I'll do this sort of history and a full H&P. There aren't a lot of absolute contraindications to hormone initiation. They would include an active hormone-responsive cancer, a blood clot that has not been treated, a history suggesting they might have a hypercoagulable state. So I have had patients in this situation, and I'll typically refer to hematology and have them undergo a workup and possibly start anticoagulation before starting estradiol in particular. Spironolactone can have a lot of side effects and issues with it, so you want to be careful with it if someone's on an ACE inhibitor, diuretics, if they have renal dysfunction or at risk of renal dysfunction or already have low blood pressure. So typically when I'm getting informed consent before starting hormones, I'll go over the physical changes with the patient, and I won't go through this line by line, but I put in red the physical changes that are permanent. So when someone's starting testosterone, facial hair and body hair can be permanent. If they lose hair, that's permanent. So if they're balding, that's permanent. Clitoral enlargement and deepening of voice is also permanent. The other changes typically will reverse if they stop testosterone. And for patients starting estradiol, again, I will kind of touch on the permanent changes, which would be breast growth. Testicular atrophy can be permanent if they're on hormones long enough, and then infertility. Everything else is reversible. Generally. You also want to kind of stress things that won't change. So skeleton, frame, height. If they already have lost quite a bit of hair, if they have male pattern hair loss, that's not going to change. Voice doesn't change, and Adam's apple doesn't change. So in general, I find patients do really well with gender-affirming hormones, but kind of the common side effects that I see in my office, with testosterone, I see some mood changes. Typically it's manageable, but sometimes you need a little help and intervention. Weight gain is common, atrophic vaginitis is common, pelvic pain, acne is usually a problem. As far as lab abnormalities, polycythemia can be common, mildly elevated transaminases, and I also see elevated LDL. And in trans feminine individuals, I find a lot of side effects are actually from the spironolactone. Spironolactone can cause orthostatic hypotension, dizziness, bumps in creatinine. Occasionally I see hyperkalemia. It's not very common. Mood issues, estrogen tends to cause more kind of depressive symptoms. People certainly notice increased emotional range, which sometimes can mean that they are crying at their desk at work, which can be problematic. Mood swings, anxiety. Trans women starting hormones often have some weight gain and some fatigue and sexual dysfunction, so decreased libido. Some patients want to maintain erections, and that can be difficult. So there are very little in the way of good studies on trans patients, unfortunately. The best studies that we have are out of the Netherlands, where all trans individuals get their care from one teaching hospital. And those studies are observational, retrospective studies. And kind of the conclusion of those studies is that when they looked at all-cause mortality, trans women did have a higher mortality rate than the general population, but the majority of that was from suicide, HIV, and drug abuse. There was a higher mortality rate from cardiovascular events, but it was difficult because the risk factors were not taken into account, so that population did have much higher rates of smoking and other cardiovascular risk factors. Also, the estradiol that was used was ethinyl estradiol, which has a higher incidence of cardiovascular events associated with it. That's the estradiol that's in birth control pills that we don't use in trans population. 17-beta estradiol is thought to be safer. Trans men did not die sooner than their age-matched controls. So, as far as risk, we think about 1% to 2% of trans feminine patients have a thromboembolic event. That risk is greatest first year of therapy if they're smokers and during the perioperative period. In 15 years, I've had 3 patients have clots. 2 of them were smokers, and 1 of them was older, and it was following facial feminization surgery, even though she'd been holding her estrogen for a few weeks before surgery. Breast cancer, again, no good data, but there doesn't appear to be an increased risk compared to general population. There have been case reports of endometrial cancer in trans men. And then, again, the cardiovascular risk is potentially increased in trans women, but we do know that it's particularly associated with ethinyl estradiol and other cardiovascular risk factors. And trans men, you often see worsening of cardiovascular risk factor profiles, so increased LDL, weight gain, hypertension, polycythemia, elevated glucose, but there appears to be no increased rate of cardiovascular events or mortality. So baseline labs, before you start hormones, the reason why this slide is kind of busy is that there's really no consensus. If you look at all the different guidelines, they all kind of say different things. So what everyone seems to agree on is a comprehensive panel and a CBC. I will also generally check a lipid panel, HIV test, and in trans feminine individuals, I do check a testosterone level at baseline because I want to have some idea of what we're working with. And if they're on antipsychotics, I do like to get a baseline prolactin level so that if they have galactorrhea down the road and you check a prolactin level and it's really high, at least you have some sense of a baseline. But I don't check prolactin level on everyone. So for trans masculine individuals, I will typically start them on injectable testosterone unless they're really happy to go slowly, they're not eager for aggressive changes, or they have a severe needle phobia. And my talk is geared towards adults, not children. So youth tend to use more topical, but adults, I generally use injectable testosterone. And I'll start testosterone sapionate around 30 to 40 milligrams weekly, and then depending on how they're doing, kind of slowly increase that over time to generally people will end up on around 80 to 100 milligrams a week. I think weekly is better because it's easier to remember to do your shot once a week, and there's a lower risk of polycythemia and mood changes with weekly injections. If people have injection reaction from cottonseed oil in the sapionate, I will switch them to testosterone enanthate, which is sesame oil. And again, topical testosterone just really doesn't work as well. It's much slower, and sometimes I've had patients on topical testosterone for years and their voice never drops. So I reserve that for people who really don't want to do shots. Also, I think it's a good option for people that have been on testosterone for several years and they've already had all the masculinizing changes and they just need maintenance. The patches I find don't really work very well at all, so I generally try and avoid those. So after I start patients on testosterone, generally the guidelines suggest seeing them every 3 months for the first year and then every 6 months. Depending on if they have underlying mental health conditions, that sort of thing, I may end up seeing them a month after they start, a little sooner, but in general I would see them for a follow-up every 3 months during the first year. And I'm just asking them kind of head to toe, what physical changes are they noticing? Are they noticing any change in their voice, change in their skin, oilier skin? Clitoral enlargement tends to happen pretty quickly. Cessation of menses usually takes several months, 3 or 4 months to happen. I'll ask about side effects. I'll make sure to tell them that if they are having side effects or mood issues, it doesn't mean we have to stop their testosterone. I just want to help them navigate this. I'll ask about documentation needs if they want to change their gender marker on any of their driver's license or federal IDs. A lot of trans masculine individuals have higher libido, have increased sexual activity, and often switch or expand their sexual preference in gender of partners and become sexually active with men. So I'll inquire about HIV, STI risk, talk about PrEP, and then also testosterone is not considered adequate birth control. So I'll also talk to them about pregnancy risk. I'll check in if they are interested in any kind of gender-affirming surgery, such as top surgery. This isn't set in stone, but typically I recommend patients take testosterone for a year before they have top surgery. And then labs, again, in this area there isn't a lot of consensus on monitoring, but I'll generally check a hematocrit to look for polycythemia, comprehensive panel look at liver enzymes, and then testosterone level. And really I'm shooting for a normal male testosterone level. So managing trans men is really the same as giving testosterone to a cisgender man with hypogonadism. I'm really just trying to get their testosterone level in the normal male range. So I'll typically check a trough level and shoot for a low normal range of around 400. You can also check a midweek level, but I find the timing in that can be a little harder to identify when they're midweek. So for trans women or trans feminine individuals, I will start androgen blockers and estradiol at the same time. Not all providers do that, but I will use low-dose spironolactone, typically 50 milligrams a day, increasing to 50 milligrams BID after about a week. If they have low blood pressure or other issues, I might start lower, like 25 milligrams. And then I will be monitoring their testosterone level because I want to try and use the least amount of spironolactone that I have to suppress their testosterone because it does have more side effects. Finasteride is considered an androgen blocker. However, it really doesn't, I don't think it works very well in terms of suppressing testosterone. It works well for male pattern hair loss, but it's pretty well tolerated. So if we're really desperate to try and get their testosterone down, I will often add it. The use of progesterone, there's no real consensus. In the European studies, that was what was used instead of spironolactone to suppress testosterone. I find progesterone in the form of prometrium does work pretty well in suppressing testosterone, so I'll use it if someone is kind of maxed out on what they can tolerate in terms of their spironolactone, and I still can't get their testosterone down. And they don't have a contraindication. I wouldn't use it in someone who is overweight or has a weight problem, really significant mood issues, or if they're at higher risk of a thromboembolic event. So someone who's older or risk factors, I wouldn't use progesterone because of potential increased risk. But a young, healthy person, I sometimes will use it to suppress testosterone. And then for estrogens, the lowest risk is going to be transdermal, so a patch. It also is not as effective as other formulations. But in higher risk people, older people, or people with risk factors, I will start the patch. And then I will usually start with 0.1 milligram once or twice a week, depending on the formulation. And then I'll max out at 0.4 milligrams once or twice a week, because after that, it's too many patches covering your body. So if that's not working, I'll switch to another formulation. I find the patch in about probably 50-60% of people, they're on max dose, and I check estradiol levels, and they're quite low. So if that happens, I'll switch to another formulation. Oral estradiol, what we have them do is dissolve it under their tongue. It's thought to bypass first-pass metabolism, so decrease clotting risk. And I'll usually start with 2 milligrams sublingually per day, increasing to about 4 to 8 milligrams, divided in BID doses. Injectable estradiol works great, suppresses testosterone. People have a lot of changes pretty quickly, but you do have to monitor levels pretty quickly because they can really get out of control, very high. So I never start anyone on injectable estradiol. I'll use that if they're not feminizing adequately on other regimens or I can't get their testosterone down. Also, a lot of people just really want injectable estradiol. So I will switch people to it and then monitor pretty closely. So for trans women, if every time I start spironolactone or increase the dose, I'll see them back relatively soon after about 6 weeks because I want to make sure that they're tolerating it, they're not dizzy, there's no lab abnormality. But generally, then it's the same kind of follow-up you do with transmasculine individuals every few months for the first year, and then about every 6 months after that. And again, I'm just kind of asking head to toe, what effects are they noticing? Side effects, are they dizzy? Are they constipated? Happens from spironolactone. Are they hydrating? Are they having issues with depression, suicidal ideation? Inquire about STI risk, HIV risk, and then talk to them about if they are interested in any surgeries. A lot of trans women will do hair removal, electrolysis, or laser, and can sometimes need help in terms of topical anesthetics to help with pain associated with these procedures. And then for labs, I want to make sure I monitor renal function and potassium, as well as testosterone and estradiol level. So testosterone level, you're trying to get to the normal female range, which is under 50. Estradiol levels, the normal female range is really variable, up to 500 in cisgender women at any certain points in the cycle. But for trans women, kind of the thought is somewhere between 80 and 250. And this level is really going to depend on the timing of their last dose and what kind of hormone they're on. So you kind of have to take these levels with a grain of salt and use it as kind of one piece of the bigger clinical picture, because these levels are going to change hourly and daily based on when they last took a dose. So for someone on injectable, I do like to check a trough, just because then if it's high, you know it's too high, and kind of go from there. But these levels can be kind of tricky. So I think that's all I have. I have included resources. Fenway in particular has a really great PDF that includes consent forms. And I've also included local resources for providers and legal resources as well. So that is all I have.